السلام عليكم.
وعليكم السلام ورحمة الله وبركاته.
Okay, guys, today inshallah we'll practice procedural skills part 2. We have for practice income, Edis, Omnia, Abbas, Rosamond, and Michael. If anyone interested to practice, you can raise your hand at any time. Again, just to remind you, the general approach of procedures, any procedure you will use needle, so you will follow this approach. Introduction, good morning, I am blah blah blah. Either registrar, may I know your name and level, please? Smile, nice to meet you. I believe you have something to discuss with me regarding blah blah blah. Mention the name of the topic. Ask two open questions. How much do you know so far about this topic? And stop. Anything specific you want to know? And stop. Then, if the actor doesn't have anything specific, then you will set learn objectives 10 points. So I will set learn objectives for you. Today I'll teach you indications, contraindication, complication, how to avoid and treat complications, alternatives, preparation for the doctor, patient, and equipment, procedure technique, steps, post-procedure management, post-procedure advice and follow-up, and documentation. Okay. This knee aspiration for income.
Yeah,
Okay. So knee aspiration, you will follow the same general approach, okay?
yeah,
So here we have indications, of course, therapeutic and diagnostic. Therapeutic to relieve the pain and the swelling, and diagnostic to know the cause. So you will take a fluid sample from the joints. Contraindication, so allergy, cellulitis, and also coagulopathy. Complications, so bleeding, hematoma, and intra-joint injury. Intra-joint injury like what? Like ligaments, cartilage, bone, anything. How to avoid? So you will use landmarks and ultrasound guidance. Treat complication, you will call orthopedic doctor if any complication. Clear?
yeah,
Okay. Um, Preparation. So patient lying flat. We will start by doctor. Okay, no worries. So at least one nurse, one doctor, wash hands, wear PPE. Patient lying flat and knee extended 25 degree. And equipment. So you will use needle, syringe, and lidocaine. And also you have two needles. This one small, so 23 or 25 gauge cannula. This for injection lidocaine subcutaneous, so skin and subcutaneous, so superficial. Clear, doctor?
yeah,
The other needle long. It will be 14 or 16 or even 18 gauge cannula. This one for aspiration deep or injection of treatment also. Treatment like corticosteroid, anything like that. Okay. So the landmark 2 centimeter lateral to the lateral border of patella. This is called lateral approach. So preparation of the patient lying flat, knee extended 25 degree, or you can say flexed 25 degree. And regarding the Preparation also, you should examine the patient, including joint effusion. Clear? Okay.
Yeah.
So regarding the steps, you will clean as usual. Clean, cover by drapes, inject lidocaine anesthesia, wait for 5 minutes, check numbness by forceps. Okay. And then you will insert the other needle, the long one. Okay. And then aspirate. Then you will send to the lab. The actor can ask you, send the fluid sample to the lab for what? Don't wait the actor to ask you. So you can say we can send the fluid sample for gross appearance, clarity, color, viscosity, and for microscopic appearance or examination for white blood cells, differential, crystals, gram stain, culture. Easy.
Yeah.
He can give you any fluid sample. So you will take how many tube? Only one. Only one tube. Okay. So the tube enough for everything, enough for gross appearance, you will see by your eyes, and enough for microscopic examination. Okay. So if he show you in the exam this tube, for example, the yellow one, he will ask you what is the diagnosis. So you can say inflammation. Maybe the fourth one, orange, you can say it's infection. Last one, hemorrhage, whatever traumatic or non-traumatic. The second one, this is non-inflammatory. And of course, the first one, very clear. If they show you in the exam, very clear like water. So you can say this is normal. Clear, doctor?
Yeah.
Okay. You have 30 seconds and 6 minutes.
Thank you. Can I start?
Yes, please.
Hello, I'm Dr. Atai, the registrar. Can you please confirm your name and your level? Nice to meet you. I understand you have something to discuss with me regarding knee aspiration. Is that right? How much do you know so far about this topic? Anything particular that you want to know? All right, today I'm going to set learning objectives for you. I'll teach you indications, contraindications, complications, how to avoid and treat complications, preparation of the doctor, the patient, and the equipment in between, then the procedure steps itself, post-procedure management, post-procedure advice and follow-up, documentation. And at the end of this teaching, I'm going to give you some website and videos so you can learn more. Is that okay? All right, so let's talk about indication. Indication, we have two major indications, diagnostic and therapeutic. Diagnostic for synovial fluid analysis and also to identify the cause of effusion. And then therapeutic, you're talking about relief of pain and pressure and for injection of some medications. You can also use it for drainage of infected fluid. Then the contraindication. Do you understand? Good. So contraindication. If the patient has got cellulitis or bleeding disorder, that could be a contraindication. And then talking about complications, you want to talk about intra-joint injury, bleeding inside the joint or infection. Are you following? Good. Now let's talk about how to avoid complications. One, you want to use steroid technique, use landmarks, use ultrasound guidance when available. And then in case you've got complication, you must refer the patient to the orthopedic team for further management. Preparation. Preparation, you need at least one doctor and one nurse. Remember to wash your hands and don your PPE. The patient, go to the patient, explain the procedure to the patient, take consent. Patient is lying supine, and then you have the knee extended to 25-degree or semi-flex. Then you gather your equipment. You have two needles. You have the small needle, 22 to 23 gauge for injection of the skin and subcutaneous tissue with local anesthesia. Then you got the large needle, that's the 16 to 18 gauge. That one is to use for aspiration and sometimes to give medications like steroids. Then you also have your normal saline, your syringe, your gauze, your drapes, intralipid, just in case there is a local anesthetic toxicity. Do you follow? Beautiful. All right, so let's talk about the procedure steps. The first thing you want to get is your landmark. So your landmark is 2 centimeters lateral to the lateral border of the patella. Then the direction, you're going inferior and posterior to the patella. Then with the knee already semi-flexed or extended 25-degree, you clean the area with your claw Hizadin, cover the area with a steroid drape, exposing the landmarks. Then you want to numb the area with lignocaine, 5 mils. The maximum dose should be 3 milligrams per kg. Then inject the local anesthesia with a small needle into the skin and the subcutaneous tissue. Wait for about 5 minutes. Then check numbness with your forceps. After that, you want to insert the long needle and aspirate. The direction of the long needle should be posterior to the patella. You're going medial and upwards direction. Then you take fluid into the tube. Are you following? Beautiful. Now, after taking the fluid, you put it in the tube, send it to the lab. You're going to be looking out for gross appearance, like clarity, color, viscosity. You're also looking out for microscopic examinations, white cells and differentials, crystals, ground stains, culture, etc. Don't forget to dress the area that you've aspirated. And don't forget to dispose your shaft into the shaft bus, under the other materials into the yellow bus. And then your working diagnosis depends on the history. And after looking at the color of the fluid, that gives you an idea of what you're thinking about. Do you understand? Beautiful. Now, talking about the working diagnosis, if, for instance, you're thinking about sepsis, for instance, you got a yellow color like what you see here, if you're getting the third one, which looks yellow in color, you're thinking about sepsis, this patient will need to be admitted under the orthopedic team, antibiotic started, fluid given. And if for any reason you get a clear fluid like the number one you're seeing there, this patient, you can safely discharge this patient home with safety netting, leaf printed leaflet, notes to the GP for follow-up in the community and outpatient referral. Do you understand? Any question?
Okay, thank you, doctor. Well done. So the station is very short, straightforward. You still have 1 minute, and in the exam you have further 2 minutes. So all procedures are short. Okay, excellent. I will give you 10 out of 10. So accuracy, you mentioned all the points, and organized, supportive, checking understanding, giving information basis, rapport, everything is okay. Safety, correct information. Thank you, Anke.
Thank you.
Next one, ADAS. ADAS. Omnia.
Hello, sorry.
Yeah,
I didn't
are
get
you
that.
there?
Yes.
Okay. So set up arterial line. It means you will teach arterial cannulation plus transducer. Okay. I will give you IDA first. So here you will follow the same general approach. Okay. So same 10 points, and you will prepare arterial line kit. So you have needle, syringe, you have guide wire, and you have dilator, you have catheter. Don't use dilator for radial artery. So you have three arteries, radial, carotid, and femoral. So regarding the procedure, you will feel the radial artery, then you will insert the needle, and then you will find the flush of blood. So what you will do, so number one, insert the needle and the syringe. You find the flush of blood and red. Then you will remove the syringe, keep the needle, insert the guide wire, number two. Once you insert the guide wire to the safe limit, you have 5 marks. Insert up to the third mark. So the third mark will be close to the skin. Clear, doctor?
Yeah.
And number three, remove the needle, keep the guide wire. So you will insert the dilator, but in radial artery, don't insert the dilator. So you can insert the catheter immediately. So thread on the guide wire. Once the catheter inside the artery, remove the guide wire, and keep the catheter. Okay, so 5 steps, easy. Once you insert the arterial cannula, okay, you will attach to what is this? Um,
Transducer. Beautiful.
okay, so pressure transducer and automatic flushing system. If you did not see in the emergency department at all, no worries. It's very easy. Even in the exam, you will see the first time. It's very easy. So you have here three-way. Three-way is down or up?
Down.
Down. Once you hold this transducer in the exam, put the three-way down. You will find
Okay.
3 points. One tubing to attach to the cannula. Tubing like the same tubing of the normal saline, right?
Yes.
Okay. And you have tubing to attach to the normal saline, the bag. And you have
Mm.
cable. Cable. You will attach this cable to the monitor. Easy?
Yes.
So number one, the three-way down. You have tubing down and the tubing up. Tubing down to the patient, tubing up to the normal saline. Clear?
Okay.
And the cable, of course, to the monitor. Just it. So the pressure bag should be up to 300. Can you see?
Yes.
And the arterial cannula and the line at the same level of the heart. Okay,
Mhm.
how to do zeroing? What does it mean zeroing? How to see the waves? Once you connect no waves, black. How to see these waves? How to see the blood pressure, invasive blood pressure? Number one, you will turn on the three-way. So this three-way control the fluid from up to the patient. So open from up to down, easy,
Yes.
and closed to the air. So what you will do,
Okay.
open to the air, open to the air. It will be closed to the patient, right?
Yes.
Then click on zero. Can you see zero button in the monitor?
Yes. Yeah.
Then you will return the three-way again as normal. You will find waves. This procedure is
Okay.
called zeroing. Easy?
Okay.
Again. So you will turn on three-way to the air. It will be closed to the patient. Then click on zero, press on zero. Then you will return the three-way again as normal. So open to the fluid and to the patient, closed to the air. Clear?
Yeah.
Okay. So regarding the indications of arterial cannulation, 3 points. So you have in frequent blood gases, frequent blood sampling, and invasive blood pressure monitoring. Contraindication if the patient has absent pulse because you will insert in the radial artery. So absent
Yeah.
pulse or inadequate collateral circulation
Technician.
or allergy, cellulitis. Okay, coagulopathy. Complications may be bleeding, hematoma, and also puncture. Puncture to the artery or puncture to the vein. So injury to the artery or vein. How to avoid? So landmarks and ultrasound guidance. Treat complication. Once the patient has any complication, call the vascular um, surgery. Alternatives, you have 3 alternative. Radial artery, you have also um, femoral, you have carotid. Preparation, so doctor and nurse wash hands or PPE, at least one, doctor and nurse. Patient lying flat, okay, and uh, rest dorsiflexed, okay. And regarding the equipment, so you will prepare needle, syringe, guide wire, so Seldinger kit, I mean, okay. Procedure steps, as we mentioned, then post-procedure management, dispose all sharp needles in sharp pen, other equipment in your box, clean and give printed leaflet advice. The patient already maybe in resuscitation and waiting for admission in ICU, or maybe the patient already in the ICU. Clear?
Yeah.
Okay. Then document all the procedure. You have 30 seconds and 6 minutes.
All right. Can I start?
Yes, please.
Hello, I'm Dr. Edith, one of the emergency doctors. May I know your name and your level, please? All right. Nice to meet you. I believe you have something to discuss with me regarding arterial line cannulation. How much do you know so far regarding the procedure? Is there anything in particular you would like to know? All right, I'm more than glad to talk you through arterial line cannulation. I will set a learning objective for us. We'll talk about the indication, contraindication, complication of the procedure, and how to avoid and treat the complication, alternatives to radial artery cannulation, preparations, procedural technique, post-procedural management, advice and follow-up to patients, and of course, documentation. So let's get started. When we talk about indication, we cite arterial line in the condition where we want to do invasive blood pressure monitoring or continuous sampling or continuous ABG monitoring for a sick patient. Talking about the contraindication, if a patient has a coagulopathy, he wouldn't be moved to go and cannulate the artery because of severe bleeding. If the patient have absent collaterals, that if the ulnar artery is not palpable, it's advisable to stay clear of that particular site. And if there is cellulitis infection at the site where you want to cannulate the vessel, of course, you have to avoid that. Moving on to the complications. Of course, you know, one of the commonest complications of arterial cannulation is bleeding, injury to the vessel itself and the surrounding vein as well, injury to the surrounding tissue. And then when we talk about how to avoid this complication, if you know your landmark, it will limit the complication. Alternatively, we can use ultrasound to avoid this. Do you follow me to this point? Any questions at all? In case I'm too fast, feel free to stop me and ask any question you will want. All right. When we talk about alternative to radial artery cannulation, we've got the carotid artery, we've got the femoral artery. Either of those can suffice. And then moving on to the preparation for the procedure. For you to do this procedure, you have to have an assistant, at least 2 people, the doctor doing the procedure and then the nurse to assist. Prepare yourself. It's an aseptic procedure. Put on your PPE, wash your hand and put on your PPE. Get your patient ready, lying down in his supine position with the arm flexed and then the wrist dorsiflexed. Try and then palpate for the artery, the radial artery, and make sure the collateral, the ulnar artery is present. You could do this by doing modified Allen's test, just to make sure the collateral is intact before you proceed. Do you follow me to this point? Once you clean the area with chlorhexidine, having gathered your materials, of course, you know, the Sedinga kit, the syringe, the cannula, and then drape with your wipes. Get all those ready before you start. And then, of course, the guard wire. Clean the area, cover it with a sterile drape. Having palpated the radial artery, you could introduce your needle gently. Once you get a flush, then you try to stabilize the needle while you bring out the syringe, while you bring out the needle. Once the needle is out, sometimes if the blood is very red, that gives you an idea that definitely is in the artery. But sometimes in those that are hypoxic, it may not be as red as you anticipated. So don't really trust on the color of the blood for you to know that it's in artery. So adequate landmark and having palpated for your vessel will suffice. Any questions to this point? Once you've brought out the needle, then you gently introduce your guard wire into the vessel. The guard wire has 5 lines. And then for you to know that it's in the vessel, at least the first 3 mark should be in the vessel. Why the third mark should be at least close to the skin for you to know that the guard wire is in the vessel. And then, having introduced your guard wire, you gently bring your arterial catheter and introduce it with the guide of the guard wire directly into the artery. As you're advancing the arterial catheter into the vessel, you are gently withdrawing the guard wire. Once the catheter enters the vessel, then you completely withdraw your guard wire and secure your arterial line in place. Having secured it in place, remember to anchor the arterial catheter into the connecting tube that goes to the transducer, the pressure transducer. And then the connecting tube has three-way that will help you fix it into the pressure transducer automatic flushing system, while you connect your normal saline on the other end. The other edge that is lateral to the transducer is the cable that connects to the monitor. Do you follow me to this point? Any questions at all? All right, let's continue. If you have a look at this blue three-way, if you see the shortest knob is pointing up and down, that's to tell you it controls the flow of IV fluid from the pressure bag into the arterial line. If you want to activate the monitor for arterial blood pressure monitoring, you have to twist the three-way into the longest knob, turn it down into the air so that it will be able to activate the monitor by pressing the 0 button on the monitor. Once you do that, you return the knob back to its normal position so that IV fluid will continue flowing freely to the patient. Do you follow me to this point? Any questions at all? Once this is connected, and then try as much as possible to discard your sharps into the sharp bin and the other remaining things into the yellow bin. Dress up the area and then thank the patient. Advise your patient on the post-procedural management and then the possible common side effect to anticipate, like simple pain, but if pain is out of proportion, the patient should feel free
Okay,
to just
thank you, doctor. Thank you. Okay, your time done. You did very well. So accuracy, you mentioned all the points, the 10 points, and the introduction. You did well. Supportive, checking understanding, give information in pieces, rubber, and regarding safety, correct information. So I will give you 10 out of 10. Thank you, Dates.
Thank you, sir.
Well done. Okay, next station. Below elbow back slap. Omnia. Omnia.
Yes, I'm here, Dr. Han. Hello.
Abbas.
Yes, sir.
Okay.
Dr. Hani, I'm here.
Omnia, I cannot hear you.
Sorry, my mic was off. I don't know why.
Okay. Are you
Can
there?
you understand? Yes, can you hear me clearly?
Yes, yes.
Okay.
Okay, so below elbow back slap, you have here communication skills. It means no teaching. You will talk to the real patient. You have another pie chart teaching. So you will teach the junior doctor or junior nurse how to do back slap, how to apply on the patient. Clear?
Clear.
So if you find teaching, you will ask the nurse and follow the same approach of teaching. Okay? I mean indication, contraindication, blah, 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 blah. But anyway, most likely it will be in the exam. I'm talking about previous exams. Application, so communication with the real patient. Clear?
Okay.
So you will go inside the room, you will find the nurse and patient. Clear? If you find the nurse and patient, two actors, so start by the nurse first. You can say, "Good morning. I'm blah 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 blah. May I know your name and level? Nice to meet you. I believe you have one patient for..."
Below elbow back slap.
Yes, for below elbow back slap. She will say yes. Please prepare all equipment. Easy.
Okay.
So this slide, this slide for teaching, and this slide for patient. If you will apply only, clear?
Yes.
So you will go to the nurse first. After the nurse, you will go to the patient. Good morning and blah blah blah. May I know your name and age because you are talking to the patient, right?
Yes.
So may I know your name and age? Nice to meet you. Smile. How can I help you? Same introduction of history. Oh, sorry to hear that. Are you comfortable? Do you have any pain? I'm here to apply back slap to you. Easy. No need to mention the term. No need to mention the term indications or contraindication or complication. You can talk about them without mentioning these terms. Clear?
Yes.
So, for example, indication, you can say, I will do, I will apply back slab after reduction of your wrist fracture. I need to do back slab for you. Done. To maintain the reduction. Clear?
Clear.
Contraindication, you can say you you don't have any open fracture, you don't have any problem in the nerve or vessels. Okay. If you don't have any of this contraindication, I will do it. You did not assess the patient yet, right?
Yes.
So you can tell him, I will see if you have any contraindication, like, for example, open fracture or any problem in sensation or in power. Clear?
Clear.
It means a neurovascular assessment.
Yes.
Then complication, it can cause some problems like compartment syndrome or pain, swelling, numbness. Okay. So we will try to make it loose. We will try to make it loose, and we are expert to avoid complications. Clear? If you have any complications, you can return. Some examiners, some examiners, they will interrupt you. Once you are explaining by this way, they will say, do the procedure. It means apply the procedure. He wants you to examine the patient, then apply stockinette, then apply cotton pad, then apply plaster bandage, then smoothing, and so on. Did you get my point? So,
Yes.
what to do in such a situation? Better to talk about indication first. So you can say, I am here to apply back slab for you to maintain the reduction. And regarding contraindication, you can ask him, can you show me your arm? I will check if you have any open fracture. I will check the sensation. Can you feel here? Can you feel here? Can you feel here? Thank you. Can you wiggle your fingers? It means can you move your fingers? Clear on me?
Clear.
If I am examining the arm, it means the point of contraindication. Easy?
Easy.
And ask about ample history. Do you have any allergy, any past medical disease, any previous surgery? Done. More than enough. Okay. Once you finish neurovascular, what does it mean neurovascular? Nerve and the vessel. So nerve, we finish sensation and the power. And regarding vessel, it means radial artery at least. So you can verbalize, I will assess radial artery. Once you finish examination, it means the contraindication finished. Regarding the complications or how to avoid or treat complications, you can talk about them after the procedure. So the examiner will not interrupt you. Easy?
Easy.
So point number 3, 4, okay, you can mention them after the procedure. So we will jump to number 6, preparation. So you can say, um, me and the nurse, we can wash our hands, wear PPE. Patient, please, can you sit for me or stand? You can do sitting or standing. Easy? So the patient is sitting or standing. Okay. So preparation of the patient sitting. You can ask the patient, can you sit for me? And the equipment, you will ask the nurse to prepare. Prepare stockinette, okay, plaster bandage, padding, bandage, and warm water, crepe bandage, okay?
Okay.
So you will start number one by stockinette. Once you apply stockinette, you will apply padding, then plaster bandage, then you will apply crepe bandage. So the first step, ask the patient after examination. You will ask the patient to extend arm in dorsiflexion. It will be pronation. Then
Okay.
you will cover stockinette. What are the landmarks? Elbow to
Metacarpal
metacarpophalangeal joints.
joints.
These are the real landmarks. Okay? These are the actual landmarks. Okay? So stockinette, it will be 10 centimeter above the elbow, 5 centimeter below the metacarpophalangeal joints.
Metacarpal
Clear?
joints. Okay.
Don't cover the fingers. Done. First step, very easy. Okay. So you can ask the nurse. In the exam, you will do? Yes. In the exam, you will wear gloves? Yes. Okay. Mandatory? Yes. So you can take the stockinette. You can measure the stockinette from here up to 5 centimeter below the metacarpophalangeal joints and cut. Then once you cut, you can put the stockinette above the arm. Easy?
Okay.
Then you will go for the second step, cotton batting. You will apply cotton batting, start from the elbow up to the metacarpophalangeal joints. Clear?
Clear.
This one. Okay. Then you will apply plaster bandage. Plaster bandage, you should put on the water gently for 1 minute, okay? And squeeze gently in the water, okay? You will apply 6 layers. So it will be 5 centimeter below the elbow up to the metacarpophalangeal joints. Easy?
Easy.
Don't cover the fingers and don't reach the elbow. So 5 centimeter below the elbow. Why? Better for flexion. Okay, then do smoothing or molding. You will do smoothing or molding. Okay, so you will put on the dorsum of the arm. Okay, once you apply the plaster bandage, you will fold the stockinette. So stockinette here, 10 centimeter here above and 5 centimeter below. Then what you will do, you will fold the stockinette here, you will fold the stockinette here, before the stockinette down here, right?
Yes.
Okay, so after that, you will apply crepe bandage.
Bandage.
Okay, the last step, like this. Okay, then you will apply collar and cuff. Easy.
Okay.
Again, you will examine. So we examined him neurovascular before, and we will examine neurovascular after. Easy.
After. Okay.
Done. So the station is very short. Once you apply, in the exam, do you need to be very perfect? No. You are not orthopedic doctor, and they are just checking the steps, not the perfection. Clear?
Okay, clear.
I mean, for example, you put stockinette like 15 centimeter above the elbow. No problem, don't worry. You put the stockinette, for example, 10 centimeter below the metacarpophalangeal joint. Don't worry, clear?
Clear.
But in verbalization, you should be accurate. When you say 10 centimeter here, 5 centimeter here. But in application, if you are not accurate, don't worry. Easy?
Easy.
Okay. Here also, if you are not accurate in application of cotton padding, don't worry. Okay, so the most important verbalize, I will apply cotton pad from elbow to metacarpopharyngeal joints. Then plaster bandage, 6 layers or 8 layers, it's up to you in the exam. So you will measure 1 layer and then put on the table and repeat. Then once you cut, put on the water and on the patient. If you are not perfect, for example, you put here, don't worry. The most important, verbalize. Okay?
Oh,
In the end, if not good, if not 100% good, no problem, don't worry. You will get 10 out of 10. The most important is the steps. Anyway, once you finish, you will talk about complications. Clear?
clear.
So you can tell him it unfortunately sometimes it can cause some complication like pain, swelling, numbness, problem in sensation, problem in movement. So if you find any worrying symptoms, you can return to ER again. I will give you printed leaflet as a charge letter to your GP, and you can follow up with your GP. You can keep dry at least 2 to 4 weeks, and you can follow up with fracture clinic. Easy?
Easy.
Okay, you have 30 seconds, then 6 minutes. So the station will be communication, not teaching. So communication here, no teaching here. Clear?
Okay. Okay.
So you will talk to the nurse and prepare equipment, then talk to the patient, okay?
Okay. Okay. Hello, my name is Dr. Omi, emergency medicine registrar. Can I confirm your name and level, please? Okay. Hello. I believe we are having a patient for below elbow back slap. Uh, so please, nurse, prepare stockinette, plaster bandage, padding, crepe bandage, and warm water. And make the patient sitting in a chair. Okay. So hello, Mister. My name is Dr. Omnia. I am here to do reduction to your wrist fracture, and also I will apply a back slap for you. Okay. So do you have any allergies? Are you on any medication? Any past surgeries? When was your last meal? Can you tell me more what happened? Okay, I'm sorry to hear that. Are you comfortable now? Do you have any pain? Okay. Now I want you to wiggle your fingers for me. Okay. So I'm touching the tips of your fingers. Do you feel that? Okay, good. Now I'm checking the radial pulse. Okay, radial pulse is intact. Okay, good. Now moving to the procedure itself. So I am going to extend the patient's arm while patient is sitting in a chair. I will apply first stockinette above the elbow by 10 centimeters and below the metacarpophalangeal joints by 5 centimeters. Okay, then I will apply cotton pads from the elbow to the metacarpophalangeal joints. Okay, then I will move to the plaster bandage. I will measure it from the metacarpophalangeal joints until 5 centimeters below the elbow. Then I will make 6 to 8 layers of the bandage. Then I will place it in warm water and squeeze it to remove excess wet water. Then I will apply it from the metacarpopharyngeal joint, the patient's arm, in the dorsum of the hand, while the forearm is extended and pronated. Then I will do molding or smoothing up. Then I will apply the crepe bandage for the no. Okay, first, before applying the crepe bandage, I will flip the stockinette from the elbow down and from the metacarpophalangeals up. Then I will apply the crepe bandage of the patient. All right. Now I am going to hang the patient's arm in arm sling and collar. Then checking again the pulse, the radial pulses. So, Mister, can you please wiggle your fingers for me? Okay. Do you feel this touching your tip of fingers? Okay, good. checking the neurovascular after applying the posterior slab. I will discharge you with a printed leaflet and discharge letter to your GP and follow up with fracture clinic after 4 weeks. Okay. Please keep this back slab dry at least for 2 to 4 weeks. Please, Mister, if you have any pain, any numbness, or any weakness, or any change in color in your arm, come back to the emergency department. Thank you.
Excellent, Omnia. Perfect. 10 out of 10. So the station is very short, but in the exam, you will apply, so it will take time. Clear?
Okay.
You still have 2 minutes, and in the exam, further 2 minutes, so 4 minutes, more than enough to apply when you are verbalizing also. Clear?
Clear.
Well done. So when you are applying Stockanet, for example, you are talking. So you will measure from here to here and then cut, then apply. Then cotton pad, apply. When you are talking, apply. So it will save time and so on. Okay, well done. You are checking understanding also for the nurse. You are checking understanding for the patient. You are giving information pieces and steps in pieces. Well done. 10 out of 10. Next one, Abbas.
Yes, sir.
Okay. So the next one, suture the wound. Suture, you will find also nurse and patient. They will put mannequin on the arm of the patient like that. Clear?
Yes, sir.
So once you go inside, you will do the same approach. So here you have teaching or communication.
Sir, teaching, sir.
Read, doctor.
Communication.
Read.
Yes, sir. Yes. Communication, sir.
Communication. So no teaching here. Clear?
Yes.
Okay. So once you find no teaching, you will go to the nurse, same introduction, and ask here. I believe you have one patient for
Suture, sir.
suture. Please prepare equipment and mention the equipment. Easy.
Yes.
So
Yes,
till
sir.
here, needle, thread, needle holder, forceps, and scissor. Okay.
Yes.
Prepare
Yes, sir.
also normal saline, iodine, and intralipid. Clear?
Yes, sir.
Okay. Then go to the patient. Introduce yourself to the patient as usual, like any history. So
Yes,
you
sir.
will say, "Good morning," and blah, blah, blah.
Yes.
May I know your name and the age? Nice to meet you. Then smile. How can I help you? Oh, sorry to hear that. Are you comfortable? Do you have any pain? Then I'm here to do what?
Sutures.
Suture for you because the wound is deep and gaping. So we finished now the indications. Easy.
Yes, sir.
Contraindication, you will ask here or him about ample history.
Yes, sir.
Okay, so any allergy, any past medical disease, any previous surgery, when was the last eat and drink, any, what about your immunization? So immunization in past medical disease and prescribed medication. Easy? Okay.
Yes, sir.
Complication, you can say it can cause some pain or bleeding. We will give you painkiller and we will numb the wound by local anesthesia. Done.
Yes, sir.
Then you will go for the procedure. So preparation, you will say me and the nurse, we can wear wash hands or PPE. Then the patient, you can ask the patient, can you lie flat? Thank you. Then the equipment, you can ask the nurse, the equipment are ready because you mentioned them earlier.
Yes,
No need
sir.
to mention them again. Okay.
Yes, sir.
Then steps. So steps, you will say, I will clean the wound from outside by by iodine, from inside by normal saline. I will be sure no foreign bodies and the wound is clean now.
Yes,
Then
sir.
you will do infiltration. Infiltration here, hold the needle, hold the needle and the syringe but no need to aspirate anything and no need to infiltrate anything. Just put the needle around the wound like that, circle. Easy?
Yes, sir.
It will take like 3 seconds. Don't waste time. Just verbalize. I will infiltrate local anesthesia around the wound and then put the needle and the syringe again on the table. Easy?
Yes, sir.
Okay. Now, 5 minutes passed. Hold the forceps, this forceps. Hold this
Yes, sir.
forceps and put on the middle of the wound. Ask the patient, can you feel here? You should verbalize.
Yes.
5 minutes passed. Can you feel here? By this forceps,
Yes.
she will say no or he will say no. It means
Yes,
you
sir.
can do sutures now. Easy?
Yes, sir.
Done. The station, until now, you will not get more than 2 marks. You should do sutures. If you will do 2 sutures, you will get 10 out of 10. If you will not do sutures, maximum 2 or 3 marks. Clear?
Yes, sir.
Your task is sutures. Okay.
Mm.
So, sutures, already you cleaned the area, already you infiltrated, then hold the needle holder by dominant hand, the forceps by non-dominant hand, and ask
Yes.
the nurse to hold the scissor. Clear?
Yes.
You will hold the needle from the lateral third.
Yes.
Don't touch the needle. You can touch the thread, no problem.
Yes, sir.
Okay. Then you will insert inside the edge of the wound. The edge will
Yes.
be half centimeter lateral and half
Yes.
centimeter lateral to the other edge, and also
Yes.
half centimeter away from the start of the edge, the wound. So
Yes.
half centimeter, half centimeter, half centimeter. You have two ways, both accepted. You can hold the edge, one edge, and insert, then the other edge and insert, or you can hold both edges by forceps and insert one time. Clear?
Yes, sir.
It's up to you. Okay. The most important, half centimeter here, half centimeter here, then you can tie. Can you see? You can hold the thread by your hand, no problem, but don't touch the needle. You will
Mm.
tie and put the tie on one edge. So this lateral edge or the other edge, it's up to you. What if
Mm.
you make tie and the tie in the center of the wound? No problem. You can hold the head of the tie by the needle holder and push to the lateral edge. Easy?
Yes, sir.
Okay. Then do the second one. Only 2 sutures. Don't make more. How many sutures?
Researchers, sir, too.
2 sutures. And the interval 1 centimeter in between.
Yes.
Okay?
Yes.
Done. Then once you finish, you will ask the nurse, clean the wound, apply adhesive dressing, and discard sharp needles and sharp pen, or you
Yes,
can
sir.
say sharp objects. You can discard sharp objects and sharp pen and other equipment in yellow pen or yellow box. Then you can give the patient advice. So advice here, printed leaflet, the charge letter, painkiller, and also keep the wound dry for at least 2 days, I mean 48 hours, and give the patient antibiotic and tetanus immunization if the wound is not clean and he is not immunized or unsure. In previous exams, the actor will say the wound in the farm and he's unsure about immunization. So you will give him antibiotic and tetanus immunization. Easy?
Yes, sir.
Okay, so you are talking to the patient in the exam. Once you are doing, talk with him. Clear?
Yes,
Give
sir.
him advice. You can tell him you can return to ER if you have signs of infection like dehiscence, pain, bleeding, pus, or the sutures opened. Clear?
Yes, sir.
Okay, you have 30 seconds and 6 minutes. You can start.
Hello, my name is Dr. Muhammad Abbas Khan, and I'm the ED registrar here. I believe you have one patient for the sutures.
You are muted, doctor. You are muted, Abbas. I think Abbas lost the signal. Anyone is happy to do this station?
I can do that.
Okay, Rosamond. So you have 30 seconds and 6 minutes.
Okay. Hello, good morning. I'm Dr. Rosimon. May I know your name and your level, please? I believe that we have got a patient to do suturing. Could you please prepare the suture tray with suture pack, everything, please? Okay. Hello, sir. Good morning. I'm Dr. Rosimon. I'm nice to meet you. May I know your name and age, please? I have got. I need to close your wound by doing the suture. Is that okay with you? We need to do suture because your wound is deep and we need to close it. First, we need to clean it with normal saline inside and outside with betadine. And I need to say, okay. I need to ask you a few questions. Do you have any allergies? When is your last meal? Did you have any past medical history? Are you on any regular prescribed medicine or any anticoagulant? Okay, so we need to do the suturing in an aseptic precaution to avoid any infection, and we use proper in sterile procedure to avoid any infection or other complications. Okay, so preparation. I've got my nurse and I have got all the equipment ready here, and we'll clean the area with normal saline inside, and outside we will do betadine, and we'll cover it with drape. Then I'll use some local anesthetic with 1% lidocaine. And I believe you didn't mention you have got any allergy. If any complication develop, we will keep intralipid to avoid any complications. Okay, is that okay? So injections is given. We'll give 5 minutes to wait, and then we'll check the sensation. 5 minutes passed. I'll check the sensation. Can you feel it?
No.
Thank you. So now we will do the suture. I will use the suture material. I have got needle holder, needle, and suture material. So what I will do, I will hold the. I will put. We both nurse and I will put sterile gloves and cover the wound with the drape. I cleaned it before, so I will hold the needle holder with right hand and with the left hand with forceps. So with the needle holder, I hold the needle divided 2/3 in front and 1/3 at the back, hold in the middle. There, 2/3 and 1/3 junction, and without touching the needle, I can touch the thread. Okay, and nurse, could you please hold the scissors so when I need it, you can cut the thread. Okay, so what I will do, I will put the first stitch to 1 centimeter away from the edge of the yeah, edge of the wound and 1 centimeter away from the last end of the wound. Okay, so I will do first one flap, and then put it in the other flap, and then twist this suture material to put a knot. The knot should be in the middle of the wound. Okay, so I'll do another suture. I'll continue this, and nurse, you will cut it. And we'll do these interrupted sutures, and after that, nurse, you can put adhesive tape. So please keep the wound clean and dry, and for 5 to 7 days, and you can go to the GP to take off the suture. And if you notice any infection, any pus, or the wound is gaping, please come back to ED. And do you have your tetanus immunizations up to date? And
I'm not sure, doctor. The wound was in the farm, and I'm not sure about the immunization.
Okay, so we clean the wound, which is good. Now, what we will do, we'll give you some tetanus injections, and we'll give some antibiotic to you to prevent any infection and any tetanus. Is that okay with you? And as we will put all the sharps in the sharp bin, and all other materials in the yellow bin. We will document. We need to document it properly. All the steps we need to document it. And as I mentioned, if anything have any infections, or if gapping away, you come back. Is that okay with you? Are you comfortable?
What are the signs of infection, doctor?
So if you see there is any pus, the wound is gapping away, or you develop any fever and wound looks mucky, oozing, please do come back.
Okay, thank you. Okay, you still have 30 seconds. Excellent, Rosamond. So the signs of infection: pus, bleeding, pain, and also open sutures. Clear?
Yeah, clear. Thank you.
Okay, well done. So I think you did very well. 10 out of 10. Thank you. Well done.
Thank you, Doctor.
So half centimeter, not 1 centimeter. Half centimeter
Half
more
cent-
than. If you mention 1 centimeter, no worries. It's up
Okay.
to you. Whatever, half centimeter or 1 centimeter. The most important, don't touch the needle itself. Okay. Well done.
Yeah,
Thank you.
thank you.
Okay. Next station. Regarding V-shape, it's not for MRChem OSCE. This one for final OSCE. Okay.
Mm-hmm.
But I will just give idea.
Mm-hmm.
You have here three layers. Three layers. The apex, and
Yeah.
this side, and this side. So you will insert 3 times. Okay.
Mm-hmm.
Insert 3 times. So first of all, close the apex. If you close the apex,
Mm-hmm.
easy to do suture for the sides. Clear?
Clear.
Okay. So number one, choose any side. So you can imagine um, line, transverse or horizontal line above the apex. This point and this point. So this line 2 centimeter in
Mm-hmm.
length and away from the apex by 1 centimeter. Clear? This one. Easy?
Away from 1 centimeter, away from apex. Okay. Thank you.
Yes, 1 centimeter away from the apex. And here, 1 centimeter away from the apex. Here, 1 centimeter away from the apex. Easy?
Easy.
So you will insert the needle 3 times. Okay. So
Okay.
from this point, so from this point,
Yeah.
okay, you will insert under the skin. You will go inside the wound. Clear?
Clear. Yeah.
This, the apex. You will insert from this 1 centimeter, this
Mm-hmm.
1 centimeter under the skin. Clear?
Clear.
Number three, you will go from inside the wound to this point again, under
Mm-hmm.
the skin.
Under this. Yeah.
Once you will do tie, it will be closed like this. Easy?
Easy.
So 3 times. From this point to this point. So from this point to this point, then this point to this point. So
Mm-hmm.
1, 2, 3.
Yeah. Okay.
Then regarding the side, you can do interrupted sutures.
Yeah.
according to the length of the worms. Okay.
Yeah.
Okay. Well done. So next station, urethral catheter.
I
Okay.
can do it's
Um,
my
you-
turn. This is,
um,
yeah.
Michael,
Oh my.
Hello, Dr. Hani.
how are you?
I'm fine, thank you. How are you doing?
Yes. So urethral catheter, the approach will be teaching. So who will decide teaching or not teaching? Check the pie chart. Clear?
Yeah, clear.
You will find here teaching and also um, mentioned in the task teaching. Okay. So you will follow same approach of teaching. Introduction, then you have 10 points. Clear? Okay.
Clear.
So indications to relieve the retention of urine. Clear?
Clear.
What else? To monitor the urine output. Maybe the patient has no urine retention. Like in ICU, any patient you will give fluids, you should insert urinary catheter. Easy?
Easy.
So, number one, therapeutic. Okay, it means relieve the urine retention. Number two, diagnostic and urine output monitoring for any fluid in any patient in ICU. So, any patient unconscious or semi-conscious or any patient in life-threatening condition, you should insert urinary catheter. Easy?
Easy.
Okay, this routine. Contraindication if the patient has obstruction. If the patient has obstruction or the patient has bleeding. So you will call the urology. Complications also same. Bleeding or urethral injury. How to avoid? So you will insert gently with lubricant. If you have any obstruction, don't proceed. Okay, Michael?
Yeah.
How to treat complication? Urologist. Alternative, you have suprapubic invasive catheter. Preparation, at least one doctor, one nurse, wash hands or PPE. In any equipment, guys, you should check the expiration date. In previous stations, in any equipment, once you reach the point of equipment, mandatory to say check expiration date. Clear, Razaman?
Clear.
Yes, sir.
So equipment, you have um, you have iodine, normal saline, syringe, cotton, gloves, and the catheter, Foley catheter. You have two ways and three ways. Two way, it means the straight way for what? For drainage. And the one with division, this one color for inflation of the balloon. Okay, Michael?
Yeah.
If you have three way, the third one will be for irrigation to irrigate the bladder. If anyone has already obstructed catheter, so you will irrigate to flush the blood clot or anything obstructing. Easy?
Easy.
Okay. So you will go for the procedure. So here, this one for drainage, you are connecting to bag, and this one, the colored one, to inflate the balloon. Okay. So this three-way, the third one for irrigation. So do you need two-way or three-way? Two-way enough. If you want a three-way, no worries. Okay. So you will clean. I'm talking about the steps now. You will clean, wash hands with PPE, and you will clean the urethral meatus. Okay. Away, you will clean away from the urethra meatus, and then after finish cleaning, you will dispose the gloves and wear another gloves. Okay. Then you can cover the genital areas from down and above by drapes. So you will drape area surrounding the penis. Okay. Then you will place a sterile receiver below the penis. Then you will inject lidocaine gel inside the urethra for 3 reasons: lubricant, analgesia, and to check any obstruction. Okay, Michael?
Yeah.
Okay. Then regarding the catheter, you will open the catheter wrapper, ensuring not to touch the catheter. So you will hold from the plastic part, clear?
Yeah.
So don't touch the catheter itself. You will insert, so hold the penis by non-dominant hand and insert the catheter by dominant hand until you reach fully, okay?
Yes.
Once you reach fully, you will inflate the balloon. Why I should insert fully? I will be sure that the balloon inside the bladder, away from the urethra, to not rupture the urethra, okay?
Yes.
Okay, so once you inflate the balloon, until you find resistance, you are pushing the syringe with normal saline, okay? Until you find resistance, don't force the balloon to not rupture the balloon, okay?
Okay.
Once you inflate the balloon, you will pull the catheter again, fully, gently. So you will pull the urethra fully and gently, clear? Why? To make the balloon very close to the base of the bladder, not the top of the bladder, okay?
Okay.
Why? Number one, sometimes the urine is little amount, so you will drain the urine. If above the fluid level, you will not drain, right?
Yeah.
Number two, the holes of the catheter will not touch the top of the bladder. It will obstruct the holes and it will bleed the bladder also. Clear?
Clear.
Okay, done. Then you will attach it to the bag. The bag should be at the same level of the bed, but not on the floor, okay? So you
Okay.
can attach to the side of the bed and dispose all equipment. Easy?
Easy.
Okay, you will monitor the flow. So preparation, it means examination also. When you reach the point of preparation of the patient, you will add examination of the patient, vital signs. You will examine also the ultrasound for the urine amount. Okay,
Okay.
so you will examine the bladder for urine amount. Okay, before and after. Easy?
Easy.
You have 30 seconds and 6 minutes.
Okay. Hello. My name is Dr. Koya. I'm one of the ED doctors. Can I confirm your name and your grade, please? Okay. Nice to meet you. I understand you've got a patient that needs a catheter passing. Is that correct? Right.
Yes, doctor. I have one patient here. He has a problem in urine retention.
Okay, that's all right. It's something I can go through with you. Have you passed the catheter before?
No.
All right, that's fine. I can definitely help you with that. So I'll just sort of talk you through the indications to pass a catheter, and the contraindications, and the complications, and then what to do about any complications, and again how to avoid them, and then the alternatives to passing urethral catheters. And the next we'll talk about how to prepare to pass a catheter, and the procedure. I'll give you some tidbits and techniques to make sure that you do it properly. And then we'll talk about the management after the catheter has been passed, including documentation and then advisory and follow-up for the patient. Feel free to stop me at any point, and I'm happy to answer your questions, okay? So So talking about indications for catheter passage, first of all, if you've got a patient in urinary retention, you want to put a catheter to relieve that retention. The other thing is for very sick patients that you're giving IV fluids, it's important to have a catheter in them to help monitor the urine output very accurately. Then when you've got patients that are in clot retention, sometimes they also need catheters to help you irrigate the bladder. And for contraindications, most times blood at the tip of the penis, especially with pelvic injuries, you don't want to pass catheters in such patients. Of course, patient refusal would be a contraindication to pass the urethral catheter. Am I clear up to this point? In terms of complications, sometimes urethral ruptures are things that happen in catheter passage. And to avoid that, you want to make sure that you're passing the catheter in fully before you inflate the balloon. So you want to pass it up to the flange before you get the balloon inflated. And then treating the complications, most of the time you need to involve urologists, the specialists, because they've got their ways to maneuver that. In terms of alternatives to passing urethral catheters, sometimes there's a more invasive technique called suprapubic catheterization. And so that's something, again, urologists would, most of the time, handle on their own. Are you clear up to this point? Have you got any questions so far? Okay, fine. So let's go to the patient now. So in terms of preparation, you start with the patient. And so you want to initially examine the patient, take the vital signs, and you want to examine the abdomen of this patient. And then you want to do a bladder scan to establish that the patient is in retention, if that's the case, for example. And then after that, you would want to explain the procedure to the patient and take a verbal consent, okay? After you've done that, you want to gather your equipment, and that would include the catheter itself, both disposable and sterile gloves, cotton wools, and cleaning disinfectants. For that, usually most trusts would have a catheter pack, so most of those things will come pre-packaged for you. And then for yourself, you want to, because this is a sterile technique, they want to make sure that you've got your personal protective equipment, including your gloves, like we mentioned earlier. Okay, so we'll just go straight into the technique now. So you want to first of all start with exposing the patient adequately. Remember, you need at least one extra person, a nurse, to assist you, and she could also be, he or she could be a chaperone. So expose the patient properly, wash your hands adequately, and don your non-disposable gloves for starters. Okay, so after you've done that, you want to clean the penis away from the urethral meatus. Okay, so as you clean, you dispose the cotton wool balls. Okay, so the next thing would be to remove the gloves that you've put on and wash your hands again. This time around, you now need your sterile gloves. And after you've done that, you would drape the patient, and then you put a kidney dish under the penis. Okay. And the next thing would be to anesthetize the urethral meatus. Now you've got, most of the time, the catheter packs, they've got those gels, and they'll serve three purposes. So first of all would be to check that the urethral meatus is free, that there are no obstructions like strictures. Again, it would help numb up the place, and to help the patient's comfort, and then it would help for easy catheter passage. So after you've done that, you need to give that a couple of minutes to work while you get your catheter ready. So you just open the tip of the catheter, and then you go ahead to advance it this time around. So you just put it in, trying to make sure not to touch the catheter at all. You usually have a plastic wrapping around it, so just hold on to that. Then as you pass it, check with the patient to make sure the patient is not in pain or any distress. Usually, sometimes they could feel a bit of discomfort, but it shouldn't be painful. And if at any point you encounter any obstruction, you should abandon the procedure and ask for help, usually again from a urologist. So once you've put in the catheter up till the flange, that's the end. And the next thing would be to inflate the balloon. At this point, you should already see some urine coming out, especially if the patient is in retention. Yeah. So you inflate the balloon. Again, sometimes they come with prepackaged solution, sterile water, which you use to fill the pots, the designated pots, which usually be colored. So once you've done that, you connect the catheter to the urine bag and then you pull it out. You pull on the catheter so that the inflated balloon rests on the bladder outlet. Now you do that to achieve two things. And first of all, you want to make sure that it's below the level of the urine so that gravity helps do the work. And then again, to make sure that the tip of the catheter does not touch the bladder wall, which could cause bleeding, discomfort. Okay. Then you connect the urine bag below the level of the patient. And then you want to check the residual volume. And then, after that, you cover the patient up. I've been talking a lot. Are you with me up to this point? Did I miss out something? Have you got any questions at all for me? Okay, fine. So that's it. So at this point, you thank the patient again, cover the patient up properly. Now you want to re-examine the patient at this point again, check the vital signs, check for patient's comfort, and just be sure that the patient is happy. In terms of post-procedural management, you want to dispose of properly all the materials you've used, and then you want to go ahead to document your procedure, okay? You want to document the residual volume of the urine, the color of the urine. You want to also document any incident. So if, for example, it was a difficult passage, you want to also make a note of that and to help the admitting team just know about this patient, okay? Yeah, so that's it. I could
Okay,
give you a
thank you,
summary.
doctor. Thank you, Michael. Okay, well done. So you covered almost all the points. You did not cover if the patient has obstruction, what to do. If the patient has bleeding during the insertion, what does it mean and what to do? If the patient has bleeding before insertion, what you will do? Okay. So what do you think?
Okay, so if the patient has bleeding before, then I'll probably do suprapubic.
So
Because
you will call a urologist.
Okay,
Call urologist. You will not do suprapubic. The urologist will do it, not you. Clear?
clear.
So you can say call urologist. He might need invasive suprapubic catheter. Okay. If the patient has bleeding during insertion, what does it mean and what to do?
So most times, bleeding during insertion could mean urethral injury. So again, I'd call urologists.
Okay. And if the patient has resistance, what to do?
So resistance could also mean a stricture. So I'd call urologists.
Okay, thank you. Okay, well done. So you will dispose all equipment and in yellow bin. Unlikely to find invasive procedure here. Clear? So the procedure is invasive, yes, invasive, but I mean no needle, no sharp equipment, I mean. Okay. So here regarding the documentation, if you will say document all the procedure, more than enough. But if the actor asks you clearly what you will document, so history, examination, the catheter size, and the ease of insertion. Easy?
Easy.
So history, it means what is the problem, the indication, contraindication, and also the complications. You will document the ease of insertion. So it was easy, it was difficult, when inserting there is bleeding or not, like that. Easy?
Easy.
Okay, well done. I will give you 10 out of 10. Thank you.
Thank you.
Okay, I think we finished now. This one. We can take break and we will do 5 stations of X-ray interpretation, guys. Okay? Okay, guys.
Okay, sir.
Thank you, sir. Yeah.
We will
Thank
take
you.
break 10 minutes and then we will continue X-ray interpretation teaching.
Okay, sir. Thank you.
In the previous year, they are giving all candidates X-ray interpretation. So I will give you some stations, and at least if they give you any different station for X-ray, you will be ready for any station. Okay?
Okay.
Okay, thank you guys. I will come back after 10 minutes.